This is week 4, biochemical genetic testing and newborn screening. The learning objectives for this week are to be able to explain the applications of gut-3 testing and mass spectrometry in newborn screening, and to be familiar with molecular testing for metabolic diseases such as MCAD. The gut-3 test. The field of newborn screening began in 1961 with a simple screening test for PKU. Dr. Robert Guthrie, who lived 1916 to 1995, was asked if he might be able to develop a simple method to monitor the blood phenylalanine level. He developed a test in 3 days. It was a bacterial inhibition assay. Please go to this video from the Boston Children's Hospital, where you can hear a little history upon what made Dr. Robert Guthrie interested in going and testing for PKU. It is a very interesting video. Newborn screening is a public health initiative. The goal is to identify infants who are at high risk of developing certain inherited diseases that have treatments and services to improve the quality of life for the child. Ethical concerns are health insurance and unequal access to testing and anxiety. By law, which varies from state to state, all newborns are tested for many rare but serious conditions. Now, the babies may look perfectly healthy at birth. However, if they're not treated, conditions can cause mental retardation, slow growth, or even death. With treatment, problems may be prevented. There's a wide variety of pathophysiological mechanisms that underlie inborn errors of metabolism, including defects in enzymes and coenzymes. It's very important to identify these children at risk because they may require lifelong care. The specific criteria for screening for a particular disorder includes the disorder must be shown to produce irreversible damage if untreated early in life. Treatment prevents the damage, but only if begun in the newborn period when the infant is asymptomatic. The natural history of the disease is known. A suitable screening test is available, and facilities for diagnosis and treatment are available. We've come a long way in newborn screening tests, and recently a new approach to newborn screening has been developed that uses mass spectrometry to detect abnormal levels of metabolites. And a few drops of blood are taken from the baby's feet, and this blood must be drawn after the baby is 24 hours old and before leaving the hospital. The sample sent to the state newborn screening lab. Now, there may have to be a retest if the sample is drawn before 24 hours. There's a problem with the manner in which the sample was drawn, or the first test results were indicative of a medical condition. Now, the physician or newborn screening program is supposed to contact the parents if there is a problem. But as happens in real life, sometimes this is not the way that it happens, and there's a lot of anxiety that some parents have had in getting their test results. This slide is showing you spots of blood on filter paper that's on a card that's to be sent to a state laboratory. This slide is showing you the process of tandem mass spectrometry. The blood samples are obtained from a standard newborn screening filter paper. The blood is passed through 2 consecutive mass spectrometers, and the resulting spectrum is read to identify various metabolites in the blood. And this whole process is going to allow us to diagnose a much larger number of metabolic disorders, and this has replaced the bacterial inhibition assay. The principle is that the metabolites in the blood samples are broken into fragments, and then the fragments are analyzed by the mass spectrometry. And tandem mass spectrometry involves 2 consecutive rounds of analysis, and it can be used to identify and quantify dozens of metabolites in a single analysis. And efforts are now underway to standardize the approach to newborn screening using tandem mass spectrometry. Some of the disorders that can be detected do not fit standard criteria for newborn screening, perhaps because the natural history is not well defined or there's no known treatment. There are, however, current efforts that are focusing on a subset of disorders that are appropriate to include on a screening panel, with the hope that a similar set of tests will be accepted as the standard across the regions of the United States and a broad change. In the case of PKU, if you were to find that the child did have elevated phenylalanine levels, the child's physician is notified and the child is referred to a specialty clinic. Blood is drawn for quantification of the phenylalanine. A value greater than 20 milligrams per deciliter is indicative of classic PKU. Some newborns fall in the mid-PKU category, 7 to 20 milligrams per DL. Both forms are treated by reducing phenylalanine levels. Less than 7 milligrams per DL is non-PKU benign hyperphenylalanemia and requires no treatment. It's usually because there are missense mutations. Medium-chain acyl-CoA dehydrogenase deficiency, MCAD, is the most common of the fatty acid oxidation disorders and occurs with an estimated incidence of 1 in 10,000 births. Approximately 60 to 80% of symptomatic patients are homozygous for a single A to G point mutation at position 985 of the MCAD gene. Tandem mass spectrometry has allowed us to add MCAD and the other fatty acid oxidation disorders to the newborn screening programs. Detection of MCAD deficiency at birth can be life-saving because affected infants and children are at a very high risk for life-threatening hypoglycemia in early childhood during times of catabolic stress caused by some type of illness, such as a viral infection, and nearly 25% of children with undiagnosed MCAD deficiency will die with their first episode of hypoglycemia. So we see that it's present clinically during periods of fasting and or illness that result in the need to increase the metabolic rate and production of energy. Patients with long-chain fatty acid defects may present with cardiac and or hepatic symptoms. Individuals with MCAD have a mild presentation, but at times of illness or metabolic need, they could actually go into a coma and die if they don't receive enough glucose. Homozygotes for the A985G mutation associated with an increased incidence of sudden infant death. The ability to tolerate fasting improves with age and growth, so that episodes of hypoglycemia requiring glucose therapy decrease as the child gets older, but there still is this need to avoid fasting and the need to consume additional glucose calories during periods of illness and in stress. And I'd like you to go to this video of a little girl who was born with MCAD, and it will bring a smile to your face because you can see that had this child not known about having this disorder, she may not have lived. And I think it was just a nice way to end talking about MCAD. This slide of a mitochondria is showing mitochondrial fatty acid oxidation and the fact that it plays a critical role in hepatic synthesis of ATP and ketones. A block in the medium-chained acyl-CoA dehydrogenase MCAD enzyme activity results in accumulation of medium-chain fatty acids esterified to coenzyme A and an impairment in energy production and ketone body formation. If you look at this slide, you can see the results from mass spectrometry, and we can see the very top, and the top is of a normal child. But then if we look at the bottom, this is a child that has MCAD, and they took a dried blood spot day 2 of life. And you can see from this that there is a peak at 347.2 is the internal standard. And then we can see that the peak of 344.2 is C8 acylcarnitine, and this is showing that the child has the MCAD. After viewing the content and looking over the videos, please go to the discussion forum for this week.